The majority of patients with acute coronary events will have a risk factor, and we acknowledge hypercholesterolemia in the United States with levels that are well above the physiologic levels. Like the normal LDL for a mammal is 50 milligrams per deciliter, and we are talking about 100 milligrams and 130 for prevention. So either though by the traditional numbers a significant amount of patients will not have risk factors, when you go to other populations and with other mammals, they will have a much lower LDL. So what the national guidelines are promoting in the last 10 years is to go lower and lower with their values. In addition, we are now recognizing new risk factors, and those include inflammation, C-reactive protein, fibrinogen, as well as homocysteine and others. So there's a lot of work to do, but we are now understanding that the current knowledge needs to be reestablished, and we have to go lower on the values for hypercholesterolemia. I do believe that thrombotic risk factors are very important both in primary and secondary prevention. Those include cigarette smoking, diabetes, and actually hypercholesterolemia as well. We know that the best antithrombotic is the one that reduces your cholesterol. We have learned from the large randomized trials with statins that thrombogenicity goes down as well. When you stop smoking, your thrombogenicity goes down in the blood. We also learned from the big fibrinolytic trials that smokers do respond very nicely to thrombolysis, suggesting that smoking is a major risk factor for plaque erosion, in which the substrate is less thrombogenic than plaque disruption.